We talked about polycythemia vera, how you treat with hydroxyurea, ruxolitinib, phlebotomy, presentation of people with polycythemia vera. We talked about erythromelalgia and all of that, right? Then we talked about Clostridium difficile infection. We talked
Yeah.
about toxin A, toxin B, toxin A, and B, those are going to be the cytotoxin and the enterotoxin that will cause diarrhea and pseudomembrane formation in Clostridium difficile infection. We talked about treatment with vancomycin, fidaxomicin, right? We talked about the mechanism of action of vancomycin and mode of
Yeah.
resistance with changing diala to diala-DLAC, right? And all of that. We talked about familial hypercholesterolemia, the person presenting with Achilles tendon xanthoma, and we said it's due to LDL receptor defect, right? Signaling defect in LDL receptor. We also talked about other types of cholesterol abnormalities, ApoE protein deficiency, ApoB100 deficiency as the alternative for hypercholesterolemia. That is, we said people with hypertriglyceridemia are going to develop pancreatitis, right? Okay.
Okay. Okay.
Yes. All right. So if a patient presented bilateral acoustic schwannomas, what comes to mind?
Bilateral acoustic. Neurofibrositoma 2. Yeah.
Now, neurofibromatosis type 2, right? What are the other findings in neurofibromatosis type 2?
Okay. Oh, it's gonna be our I don't remember. I just reviewed yesterday that,
Okay,
but I
do
know.
you remember the 2 ears, 2 eyes, 2 parts of the brain?
Yeah.
So what's presentation? What symptoms do those remind you of?
Face, eyes. I don't remember that.
Okay, so the 2 eyes were the juvenile cataracts. Do you remember that? Oh, did I say
Yeah.
two? Yes. The 2 eyes, rather, were juvenile cataracts. The 2 ears were the bilateral acoustic neuromas or schwannomas, right?
Yeah.
And the 2 parts of the brain was going to be, I think, meningioma and ependymoma, right?
Mm-hmm.
All right. Meningioma and ependymoma. Do you remember the symptoms and the presentations of the other neurocutaneous disorders?
Okay. The other one is it's not cafe, something in the skin. No.
Okay, so you would have to go through the disorders individually to get which of them is what, right? So we start with neurofibromatosis type 1. What do you find in people with neurofibromatosis type 1? First of all, what's the gene? What chromosome is involved?
The chromosome is 6.
Chromosome 17.
Yes,
You
17.
remember the alternative name for neurofibromatosis type 1, von Recklinghausen disease. So there's this mnemonic in your first aid where they say there are 17 letters in von Recklinghausen, right? So neurofibromatosis will be on type 1 is going to be on chromosome 17. What findings do we have in these patients? You have given me
Uh,
one already.
the cafe
Cafe au lait spots. Okay.
cholesterol. Yeah.
What else?
What else? Yes. Seizures.
Seizures. Okay, they could have seizures. What else?
Um, Intellectual disability.
Intellectual disabilities.
Pheochromocytoma too. That was.
Pheochromocytoma. What else? Leash nodules. Leash nodules is there, right? The
Yeah, they
pigmented
have.
findings. Leash nodules. The seizures are usually as a result of tumors that they may have in the brain, right?
Yeah.
Like a meningioma, for example. They could also have optic gliomas. Do you remember this? You remember that
Yes.
neurofibromatosis type 1, just like neurofibromatosis type 2, is also going to be autosomal dominant. In fact, all your neurocutaneous disorders generally are autosomal dominant. Which of your neurocutaneous disorders is a somatic mosaicism?
Okay. The what? The first one. The Sturger Weber.
Sturge-Weber, right? Sturge-Weber syndrome is a mosaicism. What's the alternative name for Sturge-Weber syndrome? And that's
Uh,
probably more important.
the Weinstein.
Okay, what Weinstein is defining, very crucial. There was a question where they literally gave the image of the child with a port Weinstein. What's the other name? Encephalotrigeminal angiomatosis.
And number five, the
Yes, cranial F5, right? When you think of it, you remember that the trigeminal, this name tells you that the trigeminal nerve distribution is where you usually have the presentation. So the port Weinstein is often going to be on the face, right? And then
Mhm.
they have these angiomas. So you listen to the name encephalo head, trigeminal distribution of the trigeminal nerve, angiomatosis. So what do you find in these people? Angiomas, right? You have angiomas, and those angiomas can usually, if you look at them under CT, you're going to be able to see them because they are calcified. They are calcified, and if you have any form of growth in the CNS, it can cause what? Seizures. So you expect
seizures.
these people to also present with seizures. Do you get that?
Yeah.
So and when we say angiomas, you can think of hemangiomas as well, right? And then they also present with glaucoma in many instances. Do you get it? That would be Sturge-Weber syndrome, encephalotrigeminal angiomatosis. What other neurocutaneous disorder do we have? Von Hippel-Lindau disease. What's the gene mutation? What's the problem in von Hippel-Lindau disease?
Is the chromosome 3?
Chromosome 3p. Okay, that is where we have the problem. And what is going on on chromosome 3p?
The Uoki.
There's a deletion. There's a deletion of the von Hippel-Lindau gene. It's probably important that you remember it's a deletion of the von Hippel-Lindau gene. And how do these patients present? They present with soft tissue tumors, right? Are they
Yeah.
necessarily soft tissue tumors?
Well, let me
No,
check.
no, that's more Liefeld syndrome. What kind of tumors do people with von Hippel-Lindau present with?
Hemangioblastomas,
Hemangioblastomas.
angiomatomas, and the renal
What
cell
did you say?
carcinoma. Renal renal cell carcinoma.
Bilateral, very important. I think there's a
Oh,
rapid review point on that. Bilateral renal cell carcinoma, right? They are going to have hemangioblastomas in different parts of the body. One critical part is going to be in the retina, right? In the retina. They may also have it in the cerebellum. It's not something you want to memorize. In the retina, in the
okay.
cerebellum, in the brain, different parts of the body, they can present with these hemangioblastomas, right? Just like we had in neurofibromatosis type 1, people with von Hippel-Lindau disease may also present with pheochromocytomas. Of course, they're not going to tell you this patient has pheochromocytoma. What are they going to give you? Episodic headaches, palpitation.
Mhm.
It's basically what looks like panic attack, episodes of panic attacks, right? And all of that. Of course, they're going to have increased blood pressure. In their urine, you may see increased metanephrines. These are what you find in people with pheochromocytoma, right?
Yes.
All right. Are we missing anything? Tuberous sclerosis. What happens in people with tuberous sclerosis?
Mutations of the suppressor gene.
A TSC gene,
Amor
right? I think it's TSC1.
amorti.
Is it TSC1 and TSC2
Yes.
on chromosomes
Amorti
what?
and weird.
9 and 16, right? Mutations in the tuberous sclerosis gene. Pretty easy to remember. On chromosomes 9 and 16. How do these patients present?
Amortomas.
Okay, so hematomas, I think there's a mnemonic that literally follows that hematoma name, whatever your first name, right? So they have hematomas, and they have these hematomas in different parts of the body. They could have it on the skin, they could have it in the CNS. What else do they present with?
Um, Meter rehabilitation,
Big
Ashley.
one on your exam, rhabdomyomas, right? Of course, the more obvious ones that everybody tends to know, are going to be your ash leaf spots, what else? Your chagrin patches, things like that, right? You remember all of these things.
Yeah.
You can find them in people with tuberous sclerosis as well. If you're looking for the type of tumors that these people may have in the brain, of course, they will have astrocytomas in the brain. Under they can have fungal fibromas on the fingernails, right? They also may have fungal fibromas. People with tuberous sclerosis. Delayed onset intellectual disability. They may also have, of course, they also have intellectual disability. If you remember all this information, you know your neurocutaneous disorders and will take it from them. All right. They gave you a patient with bilateral hilar adenopathy and uveitis. Okay, this one is pretty obvious. That would be what?
What is bilateral? Sorry, I don't hear that.
Bilateral hilar adenopathy and uveitis. Bilateral hilar adenopathy and uveitis. Most likely diagnosis?
Um, CMB? Oh, Bar.
No. Bilateral hilar adenopathy. You should.
Ah, yeah. Sorry. It's uveitis. Mm.
How would that be?
Mm.
Okay. In a 35-year-old African American woman.
Oh, it is the cause granuloma.
Mhm. They have
Yes, it starts with S.
it starts with an S. Okay, what would that be? That would be sarcoidosis.
Sarcoma.
Sarcoidosis, right? So this
I
is
did it.
classic presentation for sarcoidosis. Remember, it doesn't have to be a woman, it could be a man. There was a question like that where they in fact gave a man and a student said, oh, but it was a man, I shouldn't pick the answer. All right. So middle age African American woman, classic presentation, but it could also be a man. In people with sarcoidosis, you're going to have a granuloma. They may present with what do we call them? Erythema nodosum, right? Remember that people with sarcoidosis are going to have increased CD4 CD8 ratio, right?
Yes.
Increased CD4 CD8 ratio. They may also have increased calcium level. Why? Because of the activity of 1 alpha hydroxylase
Uh,
in the macrophages. You remember that?
yeah.
Because of the activity of 1 alpha hydroxylase in the macrophages. All right, you want to know that. I think that's about what is useful. Talking about uveitis. What is the disease? Where the patient has uveitis, aortic regurgitation. I'm trying to avoid the last one. Okay,
So,
and hip pain. I guess that's the way to put it to not make it too obvious. The disease where the
uh,
patient may have uveitis, aortic regurgitation, and hip pain.
with pain, I was thinking about HLP 27. So,
Perfect.
spondyl,
HLA-B27. Good job. What's the diagnosis?
rectitis, reactive arthritis.
Reactive arthritis is sort of different.
But our paper.
But reactive arthritis is one of those seronegative spondyloarthritis. This is ankylosing spondylitis, right? Ankylosing spondylitis. And what do I need you to remember with ankylosing spondylitis? Classic presentation. This is also called sacroiliitis, right? So
The the
the
the
problem is with
bamboo.
the sacroiliac joints, and they have bamboo spine. Very good. Problem with the sacroiliac joints, sacroiliitis, and they classically have bamboo spine, right? All right. They give a patient with black ishka on the face.
Oh, it's
A
the
diabetic
mucor.
patient.
Mucor.
What's the organism? Yes, perfect.
Yes.
Mucor, right? How do you manage these patients?
Hold on, manage.
How do you treat?
Mm,
Or what medication would you give to this patient?
I don't know.
What type of infection is mucorrhizopus? Bacterial, fungal, viral?
Is fungal.
Fungal. So how are you going to treat?
So fungal we can give oh yeah, nystatin, amphotericin B.
Do you think you want to use nystatin in this case?
Yes. Yes.
Amphotericin B.
Amphotericin B, yeah,
Amphotericin
ergosterol.
B. Fluconazole, right? Isofluconazole. Surgical debridement. You have to remove the dead tissue. Good. Remember, there are two major places on your exam where you may expect nystatin to be an answer, although it's not too important. Number one is the classic swish and swallow, right? What's this? Oral
And
candidiasis. You remember that?
yeah,
Oral candidiasis. And you're looking for candida vaginitis, where you use topical nystatin. Of course, you could use other medications as well, but classically, they may ask it related to these guys. What was the mechanism of action of amphotericin B and nystatin?
so they inhibit the ergosterol and they make destroy the I make pearls.
Okay,
Mm.
they make pause on what? The cell wall, cell membrane, where?
No, in the cell wall, the ergosterol.
Is it glycerol on the wall or on the membrane?
Make
On the cell membrane.
remember, yeah.
They make pause on the cell membrane. So they're not technically not inhibiting glycerol. That would be slightly wrong, right? They are making pause on the cell membrane. What medication destroys fungal cell wall?
Destroy mm,
Inhibits cell
those
wall.
azoles,
No,
azoles.
no, 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 no. What antifungal agent inhibits the cell wall?
Yeah.
What is the important component on the fungal cell wall?
The ergosterol.
No. Okay, so you have to make a
No,
distinction between the wall and
mycolic, yeah, mycolic acid, sorry. No?
mycolic acid. When you think mycolic acids, no,
Oh
no.
my goodness, I'm confused.
Okay, take your time. Fungal cell wall. So the fungi has a wall on the outside and a membrane on the inside. The cell membrane is like our own cell membrane, except our cell membrane has cholesterol and the fungal cell membrane has ergosterol, right? The fungal cell wall has beta D glucan. You remember that?
Yeah.
What was the medication that inhibited the cell wall? We established that amphotericin B and nystatin made pores on the membrane.
Yes.
So who inhibited the cell wall?
Mm, leukocysteine.
Echinocandidates. What's the medication?
Mm, I don't remember that.
Caspofungin.
Ah, caspofungin.
You still have the antibiotics template, right?
Yes.
Good.
Mm.
So caspofungin inhibits the cell wall. It inhibits specifically beta D glucan on the cell wall, who inhibits ergosterol synthesis.
Industrial synthesis. Yes, there is the azoles.
Now, these will be your azole drugs, right? Which of the azole drugs are topical azole drugs?
Topical
Which of the azole
mm,
drugs are topical azole drugs?
fluconazole.
What did you say?
Fluconazole.
Miconazole.
No, fluconazole.
Fluconazole is not really topical. So miconazole and clotrimazole are the topical ones, right? Miconazole and clotrimazole will be the topical azole drugs. Fluconazole, itraconazole, isovuconazole, those are all more systemic guys. Which of these drugs, which of your antifungal drugs, or which of your azole drugs specifically has the potential of causing gynecomastia?
Um, I don't know that.
That would be ketoconazole.
Oh, yes.
That would be ketoconazole. Which of your antifungal drugs inhibited DNA?
Ah, that was
And RNA, actually.
flucytosine.
Flucytosine, very good.
Where are my answers?
Flucytosine inhibited DNA and RNA synthesis. Does that make sense? Which of them inhibited, what do we call it? Okay, now my head is bugging.
Microtubules.
Microtubules. Which of them inhibited microtubules?
Is the glycerol.
Griseofulvin. Okay. Give me other microtubule inhibitors, other medications that inhibited microtubules
Okay.
from
Uh,
other classes generally. No.
yeah.
It
Mm,
does start with anti-cancer drugs.
mm, I don't remember it.
Anti-cancer drugs that inhibit microtubule.
Oh,
Paclitaxel,
green,
vincristine.
increasing. Yeah.
What's the other one?
Mm, don't remember.
Okay. Paclitaxel, vincristine, vinblastine. What was the side effect of vincristine?
Oh, the neur neuropathic.
Good, very good. Peripheral neuropathy. How about vinblastine?
That's I don't remember that one.
Bone marrow suppression. Vinblastine blasts the bone marrow.
Oh, yeah.
Bone marrow suppression. And then paclitaxel just takes both of them and adds hepatotoxicity to it, right?
Yeah.
All right. Which other medication inhibits colchicine? Did I just say that? Okay. What other medication inhibits microtubules? Colchicine will just be the one, right? Colchicine. I hope that's the spelling of colchicine. Colchicine is the other medication that inhibits microtubules, right? So we have griseofulvin, we have colchicine, we have paclitaxel, vincristine, vinblastine. All of those medications are microtubule inhibitors. You want to remember that.